Welcome to our webinar on the ocular tilt reaction, OTR. OTR is a classic synkinetic triad consisting of skew deviation, which is vertical ocular misalignment, conjugate ocular torsion, and head tilt towards the hypotropic eye, often with a tilt of subjective visual vertical, which is abbreviated as SVV. It represents the brain's attempt to realign the eye and head with a perceived but erroneous gravitational vertical. Physiologically, OTR is a normal otolith-ocular reflex in the roll plane. The utricle senses gravity and linear acceleration. Unilateral imbalance in these graviceptive pathways produces a triad as compensatory response to restore realignment with earth vertical. In human, this primitive writing reflex is normally suppressed to maintain the binocular vision and only becomes evident with pathology. Pathologically, OTR results from the lesions anywhere along the otolith-ocular pathways from the membranous labyrinth and vestibular nerve to the brainstem, vestibular nuclei, medial longitudinal fasciculus, midbrain integrators, especially the interstitial nucleus of Cahal. Lesions caudal to the pontine decussation causes ipsiversive OTR, while the rostral lesions in the pons and midbrain typically cause contraversive OTR. Common etiologies include posterior circulation stroke, multiple sclerosis, trauma, tumors, or hemorrhage. Clinically, OTR is a valuable localizing sign that helps distinguish central from the peripheral vestibular disorders. Patients may present with vertical diplopia or a slanted world, but the full triad, especially the torsion and head tilt, is often subtle and require careful examination with the fundoscopy, Maddox rod, or subjective visual vertical testing. Early recognition guides urgent neuroimaging, differentiates it from the cranial nerve palsies, especially the superior oblique palsy, and supports targeted management. With this foundation, let's now explore the clinical examination, imaging correlation, and the practical pulse in detail. So, I start here with this introduction. The objectives of my webinar today is number one, to understand the current use of the term ocular tilt reaction and skew deviation. Number two, be familiar with the anatomic and physiological substrate of ocular tilt and skew. Number three, know how to distinguish between skew and isolated oblique palsies at the bedside, recognizing the limitations in our understanding of cyclovertical palsies. So, why should we care about the skew? A 51-year-old woman complains of vertical diplopia for a day. Her examination reveals subtle vertical strabismus. Is it just fourth cranial nerve palsy? Can she go home? Over the next few hours, she then develops symptoms of nausea, hearing loss, ventilation problems, dyspnea, and somnolence. The MRI and MR angio shows basilar occlusion. The pre-lysis is shown here in the middle, and post-lysis, the basilar artery opens up, the patient is saved. So, overview, defining the skew, normal and pathological ocular tilt reaction, types of skew deviations with videos, skew versus superior oblique palsy. So, the dynamic horizontal vestibular ocular reflex is shown here by this animation. The person yaws his head to the right. It stimulates the right horizontal semicircular canal, and then there is a cascade of changes that leads to the contraversive eye turn. The static vestibulo-ocular reflex, that is the utriculo-ocular reflex, the graviceptive pathways for maintaining the hair in vertical position relative to the earth's vertical are not very well defined. Probably they are vestigial. Information from the vestibular nuclei ascending through the brainstem to the cranial nerve nuclei fourth and third. INC, that is the interstitial nucleus of Cahal, pretectum or thalamus, is thought to be distributed in at least 5 different pathways. They include number one, the medial longitudinal fasciculus, that is the MLF. Number 2, the ascending tract of the dieters, that is ATD. 3, brachium conjunctivum. 4, the crossing ventral tegmental tract CVTT. And fourth, which is recently observed as a ipsilateral pathway close to the medial lemniscus and possibly equivalent to the of the ipsilateral vestibulothalamic tract IVTT. This is the fifth one. The crossing ventral tegmental tract CVTT could be the efferent tract of a anti-gravitational pathway terminating at the elevator muscle motoneurons in the third nerve nuclei and comprising upstream the superior vestibular nucleus and Y group, the flocculus and the otoliths. CVTT pathway functions in parallel to the MLF pathways, which control vertical eye movements made to compensate for all vertical head movements, and may also comprise the gravitational vestibular pathways involved in the central reflection of the gravity effect. The membranous labyrinth, which contains the otolith organs, suffer from an inherent tilt translation ambiguity. Here it shows that during the backward linear acceleration, the top left, the inertial force acts in the direction opposite to the acceleration, causing the otolith membrane to lag behind the skull and sensory hair cells to bend. Similarly, the tilting head forward, the bottom left causes the otolith membrane to sag and sensory hair cells to bend as they do during the backward linear acceleration. So, a otolith recognizes the linear head acceleration which is backwards and the forward head tilt by bending the hair cells similarly. It cannot differentiate between the two. The otoliths therefore respond to both linear accelerations of the head and the head tilt relative to the gravity and cannot distinguish between the two. So what is the clinical pearl here? The motion perception is multimodal. The integration of vestibular and extravestibular inputs has important implications for the control of VOR and VSR, which function to ensure stable gaze and posture. So, what is the modern definition of skew and ocular tilt reaction? Skew deviation is an acquired vertical strabismus resulting from imbalance in the vestibular system inputs to the oculomotor system. The pathological ocular tilt reaction is a clinical syndrome characterized by combination of three phenomena involving P, postural, that is the head tilt, O, that is the ocular motor, consisting of ocular torsion, skew deviation, and P, the perceptual, tilt in the subjective visual vertical. The OTR in human beings is probably a vestigial remnant of the primitive otolith writing reflex that is released only under pathological conditions. So the physiological OTR that we are going to discuss first, the motorcyclist on a tight curve to the right tilts head and body to the right, which excites the right utricle and increases its firing rate. So the physiological OTR, the large head tilt to the left so as to reflexly reorient the head back to the gravitational vertical. The utricular efferent synapse in the right vestibular nucleus, as we have shown by the red line here in the right diagram. Utriculo-oculomotor fibers from the right side, they cross at the pontomedullary junction and ascend in the left MLF that I have shown here again with second red line. Afferents travel via the MLF to their respective cyclovertically acting oculomotor nuclei in the left midbrain. So now from the left midbrain, the right eye gets the input and it elevates from the contraction of right superior rectus. The superior rectus gets crossing fibers from the left third nucleus. It also gets intorted from the contraction of the right superior oblique. The superior oblique crossing fibers, they are received from the left fourth nerve nucleus. The left eye, it depresses from the contraction of left inferior rectus. The inferior rectus fibers are derived from the left ipsilateral third nerve nucleus. It extorts from the contraction of the left inferior oblique. The fibers derived from the left ipsilateral third nerve nucleus. So this is how a physiological ocular tilt reaction looks like. In the pathological ocular tilt reaction, here there is a lesion of the left vestibular nucleus, and therefore there is a asymmetrical graviceptive inputs. They are decreased from the left and increased from the right. The right increase is because of vestibular tone asymmetry. It is perceived as excitatory input from the right utricle. So pathological OTR in this case results in right eye being upper, that is elevated and intorted, left eye being down, that is depressed and extorted with the leftward head tilt. All other pathways are identical except for the head tilt and the direction of the torsion. So what are the differences between the pathological and physiological OTR? In physiological ocular tilt reaction, the compensatory head tilt predominates with only small skew deviation or static counter roll. In the pathological ocular tilt reaction, all three components of the ocular tilt reactions are present. So the brainstem lesions manifesting with pathological ocular tilt reaction can be divided at different levels. At the level of medulla, the clinical symptoms are and signs are vertigo and nystagmus due to involvement of the inferior cerebellar peduncle ICP, vestibular nucleus VN, nucleus prepositus hypoglossi, that is the NPH, and diplopia results from the skew or the vestibular nucleus involvement. At the level of pons, the vertigo and nystagmus, they results from the fascicle of the cranial nerve 8, middle cerebellar peduncle, medial longitudinal fasciculus. The MLF carries the anterior canal and posterior canal fibers. Diplopia results from the involvement of the nuclear cranial nerve 6 palsy, internuclear ophthalmoplegia from the involvement of MLF, or skew from the involvement of MLF. At the level of midbrain, vertigo and nystagmus occurs because of the involvement of superior cerebellar peduncle SCP, which carries the anterior canal fibers, medial longitudinal fasciculus. It results in which carries the anterior canal and posterior canal fibers. The diplopia results from the involvement of the cranial nerve 3 or cranial nerve 4 palsy. MLF results in skew, and that is also results from the involvement of the interstitial nucleus of Cajal. So this is how it is perceived. Here it is. It is important to note that the ipsilateral vestibular nucleus on the right side and the contraversive interstitial nucleus or MLF, they would result in identical lesions, with the right eye being lower for the right lower lesions and the left eye being up for the contraversive left lesions, that is the high and low. The types of skew deviations, there are several types. Comitant skew deviation, in which the hyperdeviation size remains about the same in each field of gaze due to unilateral lesion that knocks out the otolithic input corresponding to the pathways of the anterior and posterior semicircular canals to equal degrees. Number 2 is concomitant skew deviation, which is a form of skew deviation which is greater on one horizontal field of gaze and minimum in the opposite field of gaze. Is large vertical deviation in one lateral gaze with no vertical deviation in the contralateral gaze may often be a sign of isolated or associated oblique muscle palsy and should be accompanied by positive Bolshevsky head tilt test and a corresponding extortion of the hypertropic eye. Due to asymmetry in the injury to the otolith pathways, the corresponding to the anterior or posterior canals, paroxysmal intermittent skew deviation, which is a tonic ocular tilt reaction, is due to decrease in the tonic neural activity, but a phasic, that is paroxysmal or intermittent ocular tilt reaction, is due to transient lesion induces increases in the neural activity. The tilt effects caused by paroxysmal activation are opposite in direction to those caused by the lesional inhibition, such as unilateral infarction. Periodic or slowly alternating skew deviation, it is mainly due to midbrain lesions. Mostly no documented torsion or head tilt is present. Leak disease, Mendrex or methaqualone, and diphenhydramine hydrochloride overdose. Third ventricular cyst, ischemia, glioma of the brainstem, and a discrete lesion lateral to the rostral aqueduct are important causes of periodic or slowly alternating skew deviation. Lateral alternating skew deviation is because of the involvement of bilateral central otolithic pathways in the brainstem, pretectal area, the MS, stroke, Arnold Chiari malformation, basilar invaginations, spinocerebellar ataxia, lithium alcohol intoxication, and paraneoplastic cerebellar degeneration are important causes. Lastly, the transient neonatal skew deviation, it mostly resolves, but neonatal skew deviation may be a precursor of congenital esotropia. So this is a gentleman where you see the left internuclear ophthalmoplegia. Skew deviation is unveiled by alternate cover test and head tilt is there. On right gaze, there is an adduction lag of the left eye. Let's see here. And there is a nystagmus of the abducting right eye. So the lesion has to be on the left side. If skew is present and the left eye is up compared to the right, the lesion has to be above the decussation on the left side. Indeed, the right eye goes up and the left goes down. So it is likely to be at the level of decussation, above the level of decussation on the left side in the brainstem. This patient suffered from a lacuna infarct in the left dorsal pons. So this patient which I am going to show had initial presented with acute vestibular syndrome, that is acute prolonged vertigo, spontaneous nystagmus. Her Hint's examination, that is the head impulse nystagmus and test of skew, indicated a central etiology based on the presence of skew deviation and gaze evoked direction changing nystagmus. However, she also had a positive head impulse test, which is typically a peripheral sign. However, if any of the three ocular oblique vestibular tests suggest a central localization, the etiology must be assumed to be central until and unless proven otherwise. In the acute vestibular syndrome, a negative head impulse test is more helpful since it is highly suggestive of a central pathology. A positive head impulse test at the bedside must be seen to diagnose a peripheral etiology like vestibular neuritis with high degree of confidence. Although a positive hit can also be seen in central or vascular pathologies, especially the labyrinthine ischemia or a lesion involving the vestibular nucleus. Her MRI showed an acute demyelinating plaque in the left lateral medulla. And now we see the video here. The unidirectional right beating nystagmus is not shown. There you don't see a, there you see a catch-up socket on head thrust to the left, consistently present. However, there is a skew deviation. The right eye goes down, left goes up. So once a skew is present, it has to be a central. Closing the eyes, they cause the latropulsion of eyes to the left. She had an infarct in the left dorsolateral medulla. This video is courtesy from the Nanos library and it is the Daniel Gold's collection. This is a 21-year-old Kuwaiti man had cerebral palsy, retinitis pigmentosa, hypertension and renal failure. His brother, younger, and sister displayed similar findings. Ocular motility examination disclosed periodic alternating skew deviation in the patient and his younger brother. Magnetic resonance imaging showed hypoplasia of the superior cerebellar vermis with motor tooth sign. Genetic testing confirmed AHPI gene mutation on chromosome 6p23.3 in the patient and his siblings, confirming the diagnosis of Joubert syndrome. A diagnosis of Joubert syndrome is likely in adults with retinitis pigmentosa or familial alternating skew deviation. So you can see the video here. The right eye goes up and left goes down. And after some time, few seconds only, the pattern is reversed with the left eye going up and right eye going down, as you can see right now on our screen. So this pattern goes so on and so forth and this is best appreciated by abducting the eyes first on one side, that is gaze to one side and then to the other side. First let us see that the spontaneous periodic alternating skew deviation which is occurring on its own every few seconds. So on left gaze, the left eye goes up, as you've seen here right now. On right gaze, the right eye goes up. And this is almost a consistent pattern. This is a 70-year-old woman with a diagnosis of cerebellar ataxia, neuropathy, vestibular areflexia syndrome, that is the canvas. In this video, both spontaneous downbeat nystagmus, a gaze-evoked nystagmus are apparent in addition to right hypertropia in the right gaze and left hypertropia in the left gaze. It is also referred to as lateral alternating skew deviation or an abducting hypertropia. The combination of these three findings, downbeat nystagmus, gaze-evoked nystagmus, and alternating skew, is highly suggestive of cerebellar flocculus or paraflocculus lesion. This is also from the collection of the Daniel Gold from the Nanos library. So we see it here. On gaze to the right eye is up, is going down, left is going up. On gaze to the left, the pattern reverses. Left eye is up and is going down. Gaze evoked nystagmus is seen on gaze to the right as well as to the left. So this is a important article. Previously, it was thought that the lateral alternating skew deviation were mainly because of the lesions of the midbrain pretectum. So this is there are many other causes also where the Arnold Chiari malformation, lithium induced spinocerebral degeneration, multiple sclerosis, posterior circulation stroke, paraneoplastic astrocytoma in the brainstem, basilar invagination, alcoholic cerebellar degeneration, syringomyelia, head trauma, encephalitis, basilar artery aneurysm, and unknown causes. There are multiple causes for the lateral alternating hypertropia ipsilateral. 2 years back, this 60-year-old female had left thalamic IPH, that is intraparenchymal hemorrhage, with right hemiparesis, dysarthria, and vertical diplopia. 6 months later, after the initial subsidence of the vertical diplopia, episodes of vertical diplopia with oscillopsia throughout the day lasting minutes to hours at a time. MRI demonstrated hemosiderin deposition in the left corona radiata, globus pallidus, and rostral left midbrain. About 1 year following the hemorrhage, the video taken at that time was consistent with a paroxysmal ocular tilt reaction, which is abbreviated as POTR due to presumed left INC excitation or irritation. In this case, presumably related to the hemosiderin products, and her POTR was ipsiversive and included a large right hypertropia from skew deviation, ocular counter roll, top pulse towards the left ear and left head tilt. The POTR occurred every few seconds, and then the head and eye position would return normal, followed by another combined eye head OTR movement. This is another collection of the Daniel Gold's Nanos library. So, paroxysmal head tilt reaction is shown here. Look to the movements, which is torsional with the right eye going up and left going down. They would occur for several seconds, then stop, and then will recur again the very same day. And this phenomenon has occurred several months after resolution from the left thalamic intraparenchymal hemorrhage. So there is a irritative lesion in the left midbrain that is resulting in right eye being higher in the ocular tilt reaction. Seen from another angle, so the fundus examination also confirms the position of the eyeballs, and now you can see that there is a lesion because of the hemosiderin laden iron in the left anterior midbrain. This is an important Parkes-Bolshevsky three-step test to distinguish between the superior oblique palsy and the skew deviation. So we first draw out the six cardinal position of the gaze with muscles primarily involved in each position for the eye, which is the H diagram for right and left eye. So which eye is hypertropic in the primary gaze is the step one in determining we see that the right eye is hypertropic in the primary gaze. So if right eye is hyperdeviated in the primary gaze, the muscle that is paratic is either responsible for pulling the right eye down or for pulling the left eye up. So our main suspects in the right eye are right inferior rectus, that is RIR, or right superior oblique. In the left eye, the left inferior oblique, LIO, or left superior rectus are suspects. We can eliminate all other possibilities. So we circle the RSO and RIR and LSR and LIO in our drawing without having to think anything about their actions. Step 2 is the vertical deviation greater in the right or left gaze? Let's say the deviation is greater in the left gaze. This means that the paratic muscle must be either one of the muscles whose primary action is elevating eye in the left gaze, or one of the muscles whose primary action is depressing the right eye on the left gaze. The RIO and LSR both have a primary action of elevating the eye in left gaze, and RSO and LIR both have a primary action of depression in the left gaze. So simply circle the muscles on the right if the deviation is greater in the right gaze, or muscles in the left of your drawing if the deviation is greater in the left gaze. It is left here, so we have encircled with the red RIO and RSO and LSR and LIR. The third step is the vertical deviation greater with the right or left head tilt. For this example, let's now say that the hyperdeviation is greater with the right head tilt. When the patient's head is tilted to the right eye needs to turn inward, that is in cyclotorsion, and the left eye needs to turn outward, that is excyclotorsion. The muscle responsible for these actions are right superior rectus and right superior oblique, and left inferior oblique and left inferior rectus. Any of these could be paratic muscles. So simply just circle the muscles on the diagonal so that they corresponds to the direction of the head tilt in which the deviation is greater. Again, without having to think about the muscle actions. So now we can say that the right superior oblique is being encircled by all three colors, the red, the green, and the blue. The paratic muscle is therefore right superior oblique. The person suffers from the right superior oblique palsy. Differentiating between the cranial nerve palsy fourth and skew deviation is important. Certain points are hypertropia in primary position is present in both trochlear nerve palsy and skew deviation. Comitance, the trochlear nerve palsy is incomitant. Hypertropia worse on gaze to the opposite side acutely may become comitant with the time. The skew deviation may be incomitant, comitant, or alternating. The effect of head tilt on the hypertropia worse on ipsilateral head tilt in the fourth cranial nerve palsy. In skew deviation, hypertropia may or may not change with the head tilt. Lateralization of head tilt in respect of the hypertropic eye. In the fourth cranial nerve palsy, compensatory head tilt contralateral to the hypertropic eye. In skew deviation, pathological head tilt contralateral to the hypertropic eye. Direction of the torsion of the hypertropic eye. Excyclotorsion of the hypertropic eye is present in trochlear nerve palsy, while in the skew deviation there is encyclotorsion of the hypertropic eye. Associated neurological signs in fourth cranial nerve palsy, there are no other neurological signs unless caused by brain trauma or lesions in the brainstem. The skew deviation usually has other neurological signs like the gaze-evoked nystagmus, gaze palsy, dysarthria, ataxia, hemiplegia, or internuclear ophthalmoplegia. Upright supine test is very important, which is negative in the trochlear nerve palsy. In the skew deviation, a vertical strabismus that decreases by 50% or more from the upright to supine position is 100% specific for the skew deviation. So, algorithm for pathological OTR to rule out the dissociated vertical diversion is here. Vertical strabismus, rule out DVD, and pseudostrabismus, that is the dissociated vertical divergence. Rule out the mechanical restriction, then three-step test. If it is negative, it is suggestive of weakness of other cyclovertical muscles. Brain MRI with gadolinium is important. If it is positive, it is suggestive of trochlear nerve palsy. We have to do the upright supine test. If it is positive with more than 50% decrease in vertical deviation, brain MRI with gadolinium is important because we need to know the cause of acute Skew deviation. If it is negative, that is less than 50% decrease in the vertical deviation and other neurological signs are not present, then it is trochlear nerve palsy. If it is present, then brain MRI. So, dissociated vertical divergence in patient with congenital strabismus, unequal binocular visual input exerts the same physiological effect as unbalanced utricular input, producing a combined vertical divergence and cycloversion of the eyes. However, in dissociated vertical divergence, the cyclotorsion movement is opposite in direction to that seen with the utricular ocular tilt reaction. I finished my talk here. Thank you very much.